cervical margins. I'm sure nobody sees this, but this is extremely important. Suppose I'm working on a premolar. I've seen a lot of cases. Premolars has highest incidence of abfraction. Correct? The most common tooth is maxillary first premolar. Usually clinicians will overlook abfraction. I mean, this tooth is decayed now, it's going for endo. For them, the focus is do endo and give a crown. And you see, there is abfraction to start with. That means patient already is under heavy cervical stress. He's already come to you with loss of enamel. He's fractured his enamel. Rods have cracked. And now you are doing endo. You're giving him probably a post and core, I don't know, and a crown, a zirconia crown. And now what is going to happen? You've not corrected his occlusion at all. So what will fracture? Nothing will happen to zirconia. The tooth will fracture at the cervical third. So please, of cracks. Access cavity is clean now. And now I start looking at the tooth. I still haven't told my patient what I'm going to do. So I've told my patient, come, we will check. Let's plan. What can we do? So now if I'm looking at this case, first thing I see is how many walls are remaining, how many walls are missing. Everything looks good here, but cavity is pretty wide. So that means my next consideration would be thickness of remaining walls, because that is going to tell me, should I go direct or should I go indirect? So now always take a caliper like this, and when you measure the thickness of the wall, there is a rule. You can't the cuspal tip at the base of the cusp. That's thickness is very important for me, not at the top. Is it very clear? So you could use these kind of gauges, something like this, and you measure. You can get this on Amazon, you can get this from any dental dealer. It's not expensive. Okay, it's a big buckle and it tells me you have about 3.5 millimeters. So what is good for me? Distal buckle is very good for me. I'm not going to touch my distal buckle cusp at all. This 2.5 mesio buckle is good if it's a vital tooth, but it's not good if it's endodontically treated tooth. If it's endodontically treated tooth, is it very clear? This is very, very important for you to measure. And also look at occlusal overload. I already told you, unfavorable occlusion, patient is a lot of wear, presence of cracks. These are some factors which would turn your decision on the other side. So what's the important in preservation of tooth? What is most important for me? There is a hierarchy. So I just make a note. What is important? Interaxial dentine, most important. What is the least important? Residual cuspal walls. What's the second most important? Marginal ridge. Is it very clear? So for me, interaxial dentine is most important. So whenever you're working on vital tooth, please remember the cuspal thickness. If it is less than 2 millimeters, you need to cover the cusp. That's the rule for vital. If you're working on a vital, large cavities, then it's about 2 millimeters. But if you're working on non-vital tooth, I already told you the thickness limit is 3 millimeters. Measure each cusp individually. So if I have 3 millimeters all over on an endodontically treated tooth and my occlusion is favorable, I will just do direct composite. And I'll show you a lot of cases where we do direct composite also after placing a post. So I placed a post because I lost 2 walls, but at the same time occlusion is favorable, I will just do a direct composite. So it's post and direct composite. It's a very good treatment. And this is what clinical trial is ongoing at University of Siena, and what they have found is 90% of the tooth has survived over 5 to 7 years. Okay, so I'll show you the video when we go ahead. So categorize your cases. Of course, as I told you, it's always a dilemma. What should I do? But certain cases, it's straightforward. If I'm looking at cases like this, they're all direct. I know they will work. But where cases will not work is in such situations. Now it's a confusion. this is a dilemma, it's confusion. What do I do? So for example, if I'm looking at this premolar, I can see a hard tissue crack, correct? That means direct is ruled out. I have two missing walls. I have two good opposing walls. That means I need to place a post to retain the core. And then of course I could do possibly an overlay. I will definitely do an overlay. I will not do a crown for premolars. But if I'm looking at, say, this molar, I have nice about 2.5 walls. I'm missing about a wall and a half. Occlusion is favorable. You see, all the teeth are quite good. No wear. Of course, it's a good case for an onlay, conservative onlay. If I'm looking at this, all good walls, I will do a direct composite. If I look at this case, I just did direct composite, you will not believe. And it's still holding. I will show you this case. So of course, it's always a dilemma. So you need to look at those local factors and decide as to what should I do. So the point is, not every tooth you have to give a crown. That's the whole point. Okay? And of course, indirect restorations only you will do when there is loss of VD, you are doing full mouth rehabs, there is a lot of wear. These are all classical cases of indirect restorations. So, cracked tooth syndrome, please consider this in your treatment plan. So now this is my vital, this is my non-vital tooth. So for me, the question is whether I do direct or indirect. I already discussed the bonding yesterday, so I will go ahead and start with different situations. So now we'll discuss different cases. So when will you do direct? Let's look at this case. Patients come to you with multiple restoration on a first molar. There are multiple composite restorations done. Patient has sensitivity, discomfort. I'm sure there is secondary caries. There is a little bit of crack there. So we isolate first. We read the tooth before we start removing composite. So what I read is, of course, there is a proximal restoration here. There is a small proximal restoration here. There is an occlusal pit. There is a buccal pit. And of course, a little bit of restoration here on the ridge. So now I remove everything. And after I remove, I start reading. That means now this molar, which is vital, has lost two marginal ridges, but they have not lost considerable amount of marginal ridge. That's an advantage. It has a buccal pit, it has a ridge here, and it has an occlusal cavity. This is a straightforward case for me to do the direct restoration. I don't have to break my head. But the most important thing is, how do you manage contact and contour? And please remember, all these matrices which you use, they are made to work only in ideal cases. And 9 out of 10 times you don't get ideal cases. Ideal means I have a narrow cavity on the proximal. Okay, I have not broken the contact. I'm very close to the contact. Any sectional matrix will work. But when you have wide cavities, okay, sectional matrices will not work. But you need to make them work. So you need to modify them. So say for example, I'll just give you an example. So we remove all the decay. Of course, we do the bonding procedure like we discussed. Don't give bevels at the cervical margin for posterior composite. Please remember that, because the moment you give bevels, you are at risk of fracture. Keep it as a butt joint. And then what we do is we place the pallodent first. Now what I want to show you is, when I place this pallodent, I place the sectional matrix, I place the ring, and can you see a difference? See on this side, can you see the space between the ring and the matrix? This is quite small. Can you see the space here? This is quite large. How many of you observed this? If I do restore like this, what will happen? I will not get a good contour. Why? Because there is a lot of space here. Can you see this triangular space? That means now this matrix is not hugging my tooth tightly. That's very important for you to get seal and for you to get very good contour. And mostly in wider situations, it will not work. So what will you do? You will place Teflon. Push Teflon into the space. So take Teflon tape, keep pushing it. So this Teflon will push the matrix towards the tooth. Okay, I think that picture is missing. I'll show you in one more case. So you see, I convert my class 2 into class 1. I get a nice contour. Now I go on the other side. I place my matrix ring and I convert this class 2 into class 1. Now it's a class 1 situation. And please remember, everybody thinks class 1 is a piece of cake. It's one of the most difficult situation again because it's like class 5. It has high C factor. All the surfaces are bonded except one. Mesial, buccal, pulpal, buccal, lingual, mesial, distal, pulpal. Only occlusal is free. So the ratio is 5 by 1, it's 5. So in this case, please never ever connect the walls. When you place composite, do wall by wall. Take your time. Take small volume of composite. The moment you connect two walls with composite, high C factor, when you light cure, resin will shrink. So what will the composite do? It will pull the buccal and the lingual walls in the center like this. This is called cuspal strain. Correct? It will have, then it will break the bond. There will be marginal gap. And now this patient goes home and he will call you that I have sensitivity on mastication. That's because there is cuspal strain. So I will do wall by wall, slow. Follow the cusp. By default, you will get anatomy. You don't have to use any burrs to give anatomy. So I follow wall by and I finish this restoration. How long will this last? About 10 years? Easy. After 10 years, it has to fail. How will it fail? Either it will wear or it will chip. But when it fails, it's favorable. Tooth remains intact. And that's what I want. Let's look at other situation. Say, for example, I'm treating now an endodontically treated tooth with a class 1 access. All walls intact. I will just do a direct build-up because occlusion is favorable. No hard tissue cracks. H bond. Use your bulk fill flow. Restore this. This is a no-brainer. 4 millimeters in one shot. Light cure. Leave about couple of millimeters on the top for you to layer. And now you layer cusp by cusp. Do one cusp at a time. Okay, for this, of course, you need to understand the anatomy of each tooth. Of course, now I have to build the oblique ridge. I have my triangular fossa, the cuspal inclinations in place. Then I finish and polish. And I'm done. This is the same Prisma gloss what we used yesterday. And we are done. This should be your option. Because please remember, anything you do has to fail, as I'm telling you. Give patient a chance. This is what we do in most of the 4 walls intact. Now let's look at other situation. You have a class 2 access. It could be an MO or a DO. So now in this case, again it depends on the extent of your Okay, so this is a class 2 access. You see the tooth is quite small. There is no wear. It's not very wide. I have nice walls, which is remaining. That is 3 walls, all about more than 4.5, 5 millimeters. I am just going to place my matrix system. I'm going to etch and bond. Air blow, light cure. I first use my, I convert my class 2 into class 1. You can seal the orifice with SDR first. This is always a good habit, so protect your work. That's very important. Coronal seal is also very important. I convert my class 2 into class 1. And after this, you are free to remove the matrix if you want, or you can keep it, doesn't matter. So now I'm going to raise the floor with my bulk fill flow. Most important, when you're using these materials, please keep the tip in constant touch with the material when you're using. Don't lift it abruptly. And I leave about couple of millimeters to do my layering. And I go cusp by cusp. Again, follow the rule, never connect the walls. Make sure where is your primary groove, secondary groove, triangular fossa. Get good ridge which is rounded. And I'm done. So this can be a very good option for narrow class 2s which is endodontically treated. If you look at research, of course, in premolars I said it's very dangerous. So there's a lot of research which is done on premolars. And what they have found is most of them are catastrophic failures. These kind of failures you will find a lot, especially when you give crowns. So please be very careful about premolar planning. Let's look at an MOD now. Say for example, you have 2 walls missing, 2 walls remaining, and now occlusion is favorable. You don't want to give a crown for sure, but you have to place a post because 2 walls are missing. So what I'm going to do is I'm going to first place a post and core. So to do post and core, always remember from the orifice in posterior teeth, remove gutta perca only 6 to 7 millimeters. You don't need longer post because post and core failures are more common in anterior than posterior because the forces are long axis. Anterior is 45 degrees. So that's why anterior teeth require longer post, minimum 10 mm. But here I need about 6 to 7 mm. That's more than enough. So here, since I am doing a direct composite restoration, I will cut the post prior to bonding. But if I am doing an overlay, onlay or a crown, I will cut the post after bonding. Okay? So I am going to etch the tooth, the canal, the remaining access cavity, and the enamel margin. I always go adhesive approach, no self-adhesive resin cement. You're not going to get good bond strengths. So wash it off. Now I use a lot of paper points just to make sure I have removed all the etchant from the canal. Because canal is highly irregular, you never know, etchant may remain inside. So use paper points. Now I'm going to use a dual cure adhesive and I'm going to place that with a post brush. So use a post brush. There are specific post placement brushes. Don't use a round one. So these are quite long. I'm going to air blow and now I am going to light cure. Silanate the post always, unless and until your post is already pre-silanized, okay? But most of the posts available are not pre-silanized. So I'm going to use my endo tip. This is my core material which I use as a luting agent. So you can use your core material as a luting agent and as a core build-up material, okay? So I'm just going to place until the orifice level and I'm going to loop the post. Slowly tease the post into the canal. And now you're going to light cure at least for 60 seconds. And now I do direct composite over my post. So I convert the class 2 into class 1. I raise my floor with my bulk fill SDR. My post is submerged inside. So remember, it should be covered by at least 2 millimeters of composite. Don't expose your post with very thin layer of composite. Okay? So now I'm going to do my cuspal build-up. I'm going to correct my high spots, if there are any, and then I'll do my finishing, and then I will do my polish. So in certain premolars, certain molars where you feel most of the things are under your favor, but it requires a post, then it is better you do a direct composite because already you have placed a post, you have already weakened the root, and now you place a crown which is quite rigid. So the dynamics of biomechanical behavior can change. Okay? So the whole point is use the materials with the same modulus of elasticity. So it's going to behave uniformly. So we do a lot of cases like this as well. Say for example, you have a premolar like this. Again, 2 walls missing. I know it requires a post. But what is my option? Can I do an onlay in this? Yes, I can. what type of onlay. I can do it chair side. I can do it myself in front of the patient, or you can scan, take an impression, send it to the lab. That's up to you. But sometimes, just to break the monotony, we try out different things. Of course, we place the post. I already showed you. Just I'll be quick in this. I silenate. I do the core build-up. And now I prepare the tooth to receive an inlay onlay. It's a combination of inlay and an onlay. But I'm doing this with direct composite. But I'm doing it outside, not inside. How can you do that? So after you prepare this tooth, you take an rubber base impression with a triple tray. You have triple trays. Take rubber base impression, sets in 3.5 minutes. Remove the rubber base impression. You will get the prep on your impression, correct? Now in the impression you pour your dye silicone material. So you buy that from Woco, it's red in color, or you buy that from Parkel. It's a dye silicone. It's like an impression material, but it's a flexible gypsum. It's not like a rigid gypsum, it's flexible. So I can work on that model. So now I pour that and I get the model. That's my model. On this model, I make my composite on inlay onlay. I build myself. Patient is seeing this in front of his eyes. So I'm building it quickly, I'm giving anatomy. The advantage is I'm doing it outside. So shrinkage is nullified. I get better strength because I can cure multiple times. And I'm not inside the mouth, so isolation is not an issue. So something what a laboratory will do, you could do it. So we do this, we do the finishing, we check the fit, everything good, and now we transfer this into the patient's mouth. Again, the steps remains the same. You etch, bond, always make sure you have some Teflon on the other side, silanate, and use your resin cement. Okay, I will always prefer an adhesive resin cement. Don't use self-adhesive resin cement because these are non-retentive preps. So remember, there is a difference between self-adhesive and adhesive. If it is self-adhesive, you will not etch and bond the tooth. If it is adhesive resin cement, you are mandated to etch and bond the tooth. This gives you better bond strength because you get better retention. Okay, so I'm going to place this, tap cure only for 2 to 3 seconds, put my floss immediately in the interproximal area, remove all the excess, and then full cure. Okay, and then check occlusion, correct, because this is all composite, you can repolish it, no problem. So this could be one of your options. Now let's look at tabletops. So we do a lot of tabletops. These are prefabricated tabletops. These are available to you. I mean, you can buy them in different sizes. The best part is you can customize it. So this is done by my associate. I asked him to work on an extracted tooth and he started to work in my practice. So I have a center with 5 stations. So we do all such kind of work there. So this is not done by me. He's just a